Hello, everyone, and welcome to today's webinar, Molecular GI Testing, Advancing Diagnostic Stewardship and Optimizing Patient Management. I'm Christina Jewell of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by BD. To learn more about our sponsor, please visit bd.com. Now, we encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We will answer as many of your questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have trouble seeing or hearing the presentation. I would now like to welcome our speakers. Joining us today is Dr. Jose Alexander, Director, Clinical Microbiologist, Microbiology, Virology, Immunology Laboratories at AdventHealth in Central Florida. Dr. Jose Alexander earned his medical degree from the Central University of Venezuela. He is a medical microbiologist specialist, certified by the American Board of Medical Microbiology, and a fellow of the Canadian College of Microbiologists. Furthermore, he is recognized as a specialist in microbiology and molecular biology by the American Society for Clinical Pathologists. Dr. Alexander is also a board certified in Infection Control and Epidemiology, as well as by the American Council for Medical Affairs as Medical Affairs Specialist. He currently serves as the Clinical and Technical Director of the Microbiology, Virology, and Immunology Laboratories at AdventHealth Orlando. Some of Dr. Alexander's achievements include implementing rapid and comprehensive antimicrobial resistance protocols from screening and epidemiology, in addition to establishing clear algorithmic definitions for resistance mechanisms. At present, Dr. Alexander's areas of focus include antimicrobial resistance, next-generation sequencing, and the optimization of AI-driven solutions. Also joining us today is Murray Robinson, Lead of Specialty Microbiology and Molecular Diagnostics, PathLab, New Zealand. Murray has worked in both the public and private sectors. He has led many transformations in microbiology and molecular biology, including cervical cancer screening paradigm shift to primary HPV, managing COVID outbreak, and with experience in utilizing multiple molecular platforms to achieve laboratory, clinical efficiency, and performance. He has driven adoption of technologies to enhance turnaround time, including moving from culture-based technology to molecular technology for enterics testing, as well as transforming manual microbiology to automated with a BD Kiestra TLA system. And also joining us for discussion during our Q&A session today is Kayla Kirby, Global Medical Science Liaison at BD. Welcome, everyone. And with that, I would like to invite Murray Robinson to start with his presentation. You may take it away, Murray.
Thank you very much, Christy. Hi, everyone. Morning, afternoon, evening, wherever you are in the world. So I'm going to present on molecular testing for gastrointestinal pathogens. Just one disclosure, the sponsorship from BD. Just a very quick overview. Very quick look at PathLab, then GI pathogens and risk factors, the BCMAS system, a laboratory workflow from our perspective, the impact of the change that we have experienced, and then a very brief look at the enteric viral and parasite panels. Right, so PathLab, we're a New Zealand-owned private medical laboratory based in the North Island of New Zealand. I'll show you a map in a second. Microbiology and molecular are centralised to our Tauranga laboratory. We also have 3 regional hospital stat micro laboratories that I oversee, and we run 24/7 at the main laboratory. We process over 300,000 micro specimens and over 200,000 molecular specimens a year. And we've been doing molecular testing since 1999. So New Zealand, we're in the Southwest Pacific. I'm based in Tauranga in the North Island, and the blue area on the map of the North Island is the area that we provide laboratory services for, and the red dots are the 4 hospitals we service, and the white dots are where our 5 laboratories are. And we have BDMAXs in Tauranga, Whakatane, and Rotorua. The picture of the building, that's the building I'm in at the moment, that's our main laboratory in Tauranga. So let's look at GI pathogens, and the big thing is, what do you test for? The pathogen list is enormous. You've got your bacterial, viral, and parasite. And if we start just looking at bacterial, it is a massive list. And so you need to rationalize that testing. And so you need to look at the patient cohorts where you're going to have the most severe infection, and where it's important to know the pathogen from a patient management and treatment perspective. Also, obviously, public health associated with outbreaks or infection control from hospital outbreaks. There are certain pathogens that are very important from a bacterial perspective, and that will guide what you choose to test for. From a viral perspective, the testing is more often than not associated with public health or outbreak situations from a hospital infection control perspective, but also in certain immunocompromised patients, it's important to know if there is a viral pathogen and what it is from their support and management perspective. And then parasites, very important to know the particular parasite that you need to treat. And obviously, some parasites have significant public health implications. So you need to consider, what are your local pathogens? Who are your at-risk patients? What are the public health implications? And rationalize your testing accordingly. And so from a whole risk factor and stewardship perspective, this was an area we really had to look at, particularly as we saw increasing numbers and increasing requests that really were not of really good sound clinical basis. And so we looked at it from a diagnostic stewardship perspective and a severity and public health perspective, and came up with this table as far as a guide for clinicians as to when to collect samples and when there were no risk factors and there was really not going to be a lot of benefit in testing. We put this out for consultation in 2014 and made the change in 2015. Of note, molecular testing was changed in November 2018, and I'll come back to that. And in 2019, late 2019, we also made clinical particulars compulsory on all requests from a stewardship perspective. And so if we look at the impact of that, and here's a table looking at when we were doing culture-based testing and then going to molecular-based testing as far as numbers of specimens. And you can see in 2015, with the introduction of that guidance chart, we saw a big drop-off in a number of inappropriate requests. There was a little bit of a bounce back. And then again, when we introduced the clinical detail side of things, and also with molecular testing coming in, there was another drop-off. That was also partially helped by COVID, but the drop was happening before COVID came along. So we know it was those initiatives that did it. And the little toe of culture that you can see there in COVID times, that was just due to reagent supply issues. We had to do a combination of culture and molecular testing. So the BDMAX system, and these are our 3 instruments in our molecular laboratory in Tauranga. We got our first instrument in April 2017. The instruments in Tauranga we have actually gone and named after fauna in New Zealand, just our little idiosyncrasy. As far as the instruments, the second one was associated with getting ready for the enteric testing, and then the other 3 were all associated with COVID, but now continue to be used for a broader range of respiratory pathogen testing. Looking at the kits, and there is a massive range of kits you can run on the BDMAX. One of the actual really great features about it, the ones I've grayed out are the respiratory kits that we've used previously. We're now using the BDRVP kit, the HSV kit, and we'll talk more about the enteric bacterial and extended bacterial kits. We're also doing Bordetella. The MAX is our backup instrument for our CBGC-TV testing, mpox, some of the resistance genes, and the enteric and parasite we have just been working on. In fact, we've just gone live with the enteric viral, and the other two kits I mentioned there, we're planning to look at later this year. So let's look at the enteric bacterial panel and extended panel. Why did the BDMAX enteric panel become necessary, or why did we go down that line? What was our motivating factor? Well, up until December 2015, we were fully manual microlab. In January 2016, we got BD Kestra TLA. And by mid-2018, we were actually reaching capacity in our aerobic incubators. And so the question was, should we purchase another incubator, or should we consider other options? Feces culture required the most number of plates. It didn't have the highest number of specimens, but it did have the most number of plates in the incubator. There was an increasing clinical demand for broader testing, more sensitive testing, and we were looking specifically at molecular from that perspective. And the enteric molecular testing also had the potential for laboratory workflow, staffing, and turnaround time benefits. And of course, removing feces from Kestra would have the greatest impact on our incubator capacity. So we decided to investigate what feces molecular options were available to us. We considered several options, but decided to trial the BDMAX system. It detected all of the severity and public health pathogens, as I'd mentioned earlier, that we wanted to detect. It was flexible. We didn't have to do the bacterial, viral, and parasite all at the same time. We could select what and when and how. It was easy to use, and that was really the big selling thing for us, was the ease of use of the system and of the sample setup. It was scalable, and we certainly have scaled with time, and it was also cost effective. So these are the targets that are in the enteric bacterial and the extended enteric bacterial side of things. And most people will have been looking for the four enteric bacterial. The question I'm sometimes asked is, why do we go for the extended? So the primary reason was Yersinia enterocolytica. For us, under culture, it was the third most common enteric bacterial pathogen we grew. But it's the old story. It turns out you don't know what you don't know until you start looking for things more widely. And ETEC, which we really thought was just a traveller thing, we found many cases associated with New Zealand residents who hadn't travelled. Plesiomonas, which again we really saw as a traveller thing from the tropical regions. Turns out that New Zealand has a summer peak, and in fact this graph is looking at the situation in New Zealand when we were in COVID lockdown, so we know there was no overseas travel, and these were all the cases we had. So definitely a local infection as well. And also with the Vibrio, we picked up a number of muscle-associated outbreaks that we would have missed had we been doing culture-based techniques. Laboratory workflow, that change from culture to molecular. And so this was our basic workflow with culture before we went to molecular. So those first four blue-green boxes are the setup of the sample when we first receive it, checking it, labeling everything, inoculating the plates and broths and putting them into the incubator. The next four boxes are that incubation, your identification and purity plates after reading, any identifications, and then obviously the re-incubation of plates and purity plates, and again your incubation step, and the same things again. The box with the red outline, that's where most samples sort of finish up, so after a couple of days, but there are always those ones that sort of carry on a bit further because you've done another purity plate or there's an ID you're still actually waiting on. So many steps over at least 2 days, possibly 3 days to get a result. And so looking at it from a BDMAX perspective, the first 3 steps are actually identical, except instead of labeling 4 to 7 culture plates, we are looking at labeling a single tube. And then once that tube's inoculated, for us, We hold that overnight until testing the next day because most of our work comes in late afternoon into our evening shift, and we've chosen not to run them that night. They could just go straight onto a BDMAX if we had the staff to actually do that. Then the next morning, it's about 20 minutes per run to set it up, and the run time's just over 3 hours, after which we review the results, the controls, the curves of the positive samples, and then release them and report them out to the clinicians. And so what was the impact of this change? So culture to enteric, as I mentioned, we had the capacity issues. We didn't have to buy any more Kestra capacity. There was increased demand for clinical demand for molecular testing, and we were able to offer that with a greater range of pathogen targets and improved sensitivity. We had increased specimen numbers, and we had the potential to decrease those numbers, and I'll show you where that went. There was increased cost and pressure on staff. With the molecular testing, it was a similar cost and reduced staff requirements with improved turnaround times. So this is looking at our data. The enteric PCR, which was the first 4 months, so we went live. We then compared it to the equivalent 4 months in the preceding year of doing culture. The other thing to note is that we've got about 700 samples less in the 4 months of doing enteric PCR compared to the culture side of things. And there is a change here. Some of that's because of the increased targets we're getting with the molecular panel. For example, ETEC, we couldn't test with that with a culture-based side of things. And with STEC, we could only get E. coli 0157 with the testing we were doing previously. And obviously with the molecular testing, we were picking up all of the STEC. So hence quite a big change in the percentage of pathogens. But if we go and look at numbers, it tells an even better story, I think, as far as the additional pathogens that we were picking up over this time, and huge increases. Obviously, the Plesiomonas, as I mentioned, we didn't realize we had so much locally. The STEC, more than just our E. coli 0157, ETEC, which we couldn't pick up before, Vibrio, our outbreaks, and then Campylobacter. We were missing a quarter of the pathogens there, so a massive increase. And if you look at it from a few numbers perspective, the percentage increased sensitivity, culture 7.9% of samples were positive. With the enteric PCR, it's 15.3. So from a requester impact point of view, you've got a diagnosis in a lot more cases. From a patient management point of view, improved patient management as far as treatment, either starting or stopping antibiotics as appropriate. And from our perspective, increased targets we can offer and an improved service to our patients. And turnaround time. So here's the graph of comparing 2015 on culture and last year on molecular. Now, I should explain the little blip last year. That was actually when we were installing our GX onto our BD Core PXMX system where we run our STIs. And so they all had to move to our backup, which is BDMAX. And so the BDMAXs were having to be shared between our STI testing and enteric, which didn't normally happen. Hence the blip. It's nothing to do with enteric testing per se. The other point I would make is that we had a huge improvement, halved the time to result, and we could improve that further if we ran those samples straight away once we'd inoculated them. We choose to have them sitting there for about 12 hours, maybe not quite that, 8-10 hours. And so we could get this down in between that sort of 10-20 hour time quite comfortably if we ran them straight away. And then looking at numbers, so where the blue arrow is, that's the point at which molecular testing came in, and you can see our numbers drop. The big dip to the right is COVID testing. But looking at that 12 months before we were doing molecular testing to the 12 months after, we saw a 19% decrease. Why the decrease? Well, we think it was a number of things. One was the quicker turnaround time. Clinicians were getting the result. They knew the outcome for their patient. They didn't or weren't tempted to send other samples. The increased sensitivity, obviously we're picking up lots more pathogens, so there doesn't need to be lots of other tests and investigations. And it was that whole education as far as we've brought in this new test. It's a lot more sensitive. You don't need to be sending us multiple specimens. So the introduction of this panel for us was really good diagnostic stewardship. Culture, yes, we still do culture. We culture some of our positive samples, Shigella, Salmonella, Yersinia, Vibrio, from a public health epidemiological point of view, so that can be typed looking at outbreaks. As far as other targeted culture, that's very much associated with clearance samples because the molecular testing is just too sensitive. So culture is beneficial there, or specifically requested by clinical microbiologists or infectious diseases physicians. So looking very briefly at enteric, viral and parasite side of things, why now? Well, from a viral perspective, we do have a broad spectrum syndromic panel for GI testing. The thing is that we don't always want to test all of those targets. It's not good stewardship. It's not the best way to go. And so using the enteric viral panel on the max with the 5 targets is more cost effective. It's more target specific based on the clinical symptoms of the patient, or if it looks like it's a viral outbreak. And so from a diagnostic stewardship, far better. And also improved sensitivity. We had been using a rotavirus antigen test, and we found that we had a number of false positives, which were picked up by the molecular testing. And so we knew we had to make the change from that perspective. Verification's gone really well, and we've now changed to this particular kit. The astrovirus was a little less sensitive than some others available, but not so much so that it will have a negative impact on what we do. And the enteric parasite panel. Now this panel targets Giardia, Cryptosporidium, and Entamoeba histolytica. We are specifically looking at the E. histolytica side of things and as a backup for Giardia crypto. So we've got other methods for Giardia crypto. We're going to look at using this kit where there are requests for E. histolytica. And that was prompted by conventional tests being very time consuming, requiring a very high skill level and ongoing competence. And in fact, it was flagged by our accreditation authority last year that we should maybe look at molecular options because of the small number we do and because of the highly skilled staff you need to maintain. And this might be a better way to go for us. And of course, it differentiates from the Entamoeba dispar, which conventional tests can't do. We've done the initial verification work on this, and excellent concordance. In fact, there was 100% agreement in our first panels we run. We want to run some more positives just to be sure, particularly more E. histolytica before we go live with it. So just very briefly in summary, the BDMAX offers us a very wide range of assays. It's flexible. It certainly has improved our workflow. It's given us a very much reduced time to result. It's increased the sensitivity hugely, and it's really helped promote our diagnostic stewardship goals. The racks here are our cartridge holders, upcycling of things. This is a toast rack on the right, a little bit of foam waste and some metal waste on the left. So always good to upcycle. I'd just like to thank you all for listening. Also want to thank BD for this opportunity. Nicholas Zacci, who's my lead scientist in molecular and has done all the work setting up these tests. To the micro and molecular teams who do all the work. To Dr. Vani Sathyendran, one of our clinical microbiologists who shared the enteric molecular data. Diane McQueen, our CEO, who has been so supportive of us bringing all of these changes in. So Thank you, everyone, for listening. I'd now like to invite Dr. Jose Alexander to share with us.
Well, thank you everyone for attending to this presentation. My name is Dr. Jose Alexander. I'm a medical microbiologist and Director of Microbiology for the AdventHealth system. So the presentation that I will be showing today is about the stool culture to PCR. Is how to optimize the GI testing from culture to PCR. Here are my disclosure. This presentation on behalf of BD and is in regard of IVD or FDA clear product. And this opinion and clinical data is for informational purposes only. And also this is a compensated presentation by BD. To start, let's just put in perspective how this test was implemented specifically in the AdventHealth system. And the Central Florida division is a large facility. It's one of the biggest hospitals across the U.S. Have around approximately 2,247 beds, and this is the main campus in Orlando. There is an additional 1,549 beds across 7 other hospitals in the same area, Central Florida. We have a large microbiology laboratory that include virology, bacteriology, parasitology, ASB, fungi, and molecular. And in total, it's around 75 clinical laboratory scientists with 2 managers, 7 supervisors. We handle a large amount of microbiology samples for microbiology testing. And this is on an annual basis. So how we got to molecular diagnostic on GI testing? So in 2017, the DSA released these guidelines for the diagnostic and management of infectious diarrhea. And these guidelines actually make a little more formal beyond the point of working on the plates and looking for organisms, but also the PCR based on some of the platform that was in that moment on the market, like the Verigene for the GI tract for enteric pathogens, that we can use PCR for rapid identification of some of these pathogens, not only bacteria, but we also can include some of the viruses. So this for us was the initial of the conversation that was necessary to move from the stool culture that was being traditionally done to a more rapid and less time consuming, but even more sensitive method as the PCR. You can see that in these guidelines emphasize what are the major pathogens that are included and also in the perspective of the clinical presentation. Traditionally, it's always considered that the culture are cheap, and it's true. I mean, it's only a few plates if we put that in perspective of the reagent for a PCR, for example. But when we put the culture in perspective of the whole workflow that goes around the culture, not only plate, but identification, testing, any additional reagent, incubation time, and especially in labor, we can see that based on our analysis in 2017, the cost for culture was around $67. And one of the reasons of that is a technically challenging culture. We have a lot of the GI microbiome growing on the plate, and we need to look into those organisms, which one are real true pathogens. The turnaround time was around 7 days, and it's only intended for bacteria. And this was another important factor. We have a lot of organisms growing, enterobacteriales and non-fermenters. Some of them morphologically look like some of the pathogens, and they require specifically testing. In our case, in that moment, we use the Vitek ID card for gram-negative. So every time that we found an organism, they have a suspicious morphology. We have to run a Vitek card. That also increased the final price of the entire culture. And was labor intense. So every plate take around 15 minutes per day reviewing all the colonies and the growth pattern that was on the plate. So we need to review that for multiple days until we finally can feel sure that we rule out any potential pathogen to be detected, or we were able to detect a pathogen. In addition, not only we have to do the culture, but we also have to do the Shiga toxin testing. When the specimen was placed in a GM broth, and the GM broth was tested to looking for a specific production of toxin. if we see the cost of the stool culture, if we see the improvement that we did to the stool culture with the PCR, there was a significant improvement. One of them was the turnaround time. We went from 4 hours, specifically from the 7 days on the traditional culture, and that was a significant improvement because now we are able to rapidly rule out negative, but in the same time report those that are significant detection. The labor also have a significant decrease. We went from 15 minutes per plate per day. We went down to 5 minutes just one time in the moment that we set the sample. So we also were able to expand detection to multiple other bacteria. We also were able to identify viruses and automate, in this case, the detection of Shiga toxin without needing to do additional testing, all in one test. And so the saving in labor was significant. And this was what allows to put all the transition from culture to PCR in a better perspective. So in 2021, we optimized our stool PCR panel. And there was a few reasons why. One, we needed an expanded panel. We needed to make sure that we include other significant pathogens, not only bacteria, viruses, but we also wanted to be able to transition from an antigen testing-based parasite to PCR. And that was to be able to offer a more comprehensive approach. We're also trying to offer a flexible panel by clinical presentation and differential diagnosis. So we want to make sure that patients are being tested based on differential diagnostic and clinical suspicions. If a patient don't have criteria for parasites, we want to make sure that patient is not tested for parasite routinely. And also we're looking for a scalable instrument. We're looking for an instrument that was able to expand the menu of testing based on the different approach and different needs that we have in the laboratory at that moment. So at that point, we found that the BDMAX platform was flexible enough to offer this expansion of the current GI testing, but also be able to be a platform that we can expand to other testing, different other tests in the future for different other conditions. So when we move to the BDMAX enteric panel, and you can see here involved in the list of organisms, that was the expansion that we did. So the enteric bacterial panel was the same, but we actually were able to extend to the enteric bacterial panel that include enterotoxicanic E. coli and the Plesiomonas shigelloides. Those two were significant organisms that we didn't have before with the very gene, but also at that point, we didn't have enough information about the prevalence. In the viral panel, we include 3 new viruses, sapovirus, astrovirus, and adenovirus. And we now have a full enteric parasite panel that increase our sensitivity and also the workflow to be able to test for these 3 more significant and prevalent parasites. And the best way that we implement them was having 3 individual orders. So we have a gastrointestinal bacterial panel that includes the enteric bacterial panel and the extended panel that was intended for patients that have symptoms that clinically match with a bacterial GI infection. We also have an intestinal viral PCR panel and the parasite PCR panel. We did not include a whole comprehensive 3-panel, 1 order, because we make sure that for the perspective of the clinical diagnosis, we want to make sure that the test is guided by the clinical presentation. And we also know that this will facilitate, specifically from perspective of revenue for having this panel, to be able to engage with third-party payers at the moment to be able to claim some of these panels. The panel will be defined by the clinical presentation. So this one gives us the opportunity to offer these 3 panels, and we also offer educational material. We engage with clinicians and show them just to reinforce that the clinical finding, the suspicious diagnostic in that moment was able to guide for the specific test that was required. So we have different order criteria. So for PCR, and this could be only ordered in outpatient and inpatient, but within the 3 first days of admission. We want to make sure that after the 3 days of admission, the clinical suspicion in that case can also target a potential Clostridium difficile, because we know after the 3 days of admission, based on some data review that we perform in our facility, the probability of bacterial infection was minimal. So suddenly onset of watery or bloody diarrhea, abdominal pain, suspected consumption of contaminated food or water, fever with or without vomiting, history of recurrent antibiotic use. In this case, for C. difficile, it was a completely different approach with a double-step algorithm, and if there is known of any outbreak of Salmonella of E. coli. And the same we did for viral infection, watery diarrhea with low grade fever, vomiting, abdominal cramps, usually self-limited, common in children, they have seasonality. So this was the education material and the clinical guidance that we offer for this particular panel that was based on only the 5 vital targets. In the case of parasites, we also offer information, persistent diarrhea often more than 7 days, abdominal bloating or cramp, travel endemic area, fatigue or weight loss, patients that are immunocompromised, or consumption of untreated water. So as you can see, for bacteria and parasites, we have the limitation that can be only ordered in admitted patient with the first 3 days of admission. In the case of viruses, we don't have that restriction, because we know that, especially in pediatric patients, there is a possibility that there could be a viral infection happening in an admitted patient after 3 days. So based on our data, we want to make sure that we have a rational clinical approach, but we also want to make sure that we take an epidemiological consideration, so we allow the viral panel to be available. Now, these are alerts that we have built in our system. We use EPIC. And when the patient has more than 3 days of admission, and the clinician want to place an order for parasite PCR or bacterial PCR, there will be an alert notifying that the probability of one of these tests to be positive is very low. We documented less than 2% for bacteria and less than 2% for parasite. So, and we allow the clinician, given that additional information, for them to take a decision if continue with that order or not. So the implementation of the enteric BD panel, the BDMAX, allows to improve the cost, appropriate panel guided by clinical suspicion, so guided order based on clinical presentation, avoid overutilization. Patients that don't have criteria for parasite diagnostic or testing doesn't really require to have that test. Was a stepwise approach. We don't reflex the next step, but since we had the specimen in the laboratory and the original order was negative, say as an example, the clinician ordered the viral test and the viral test is negative, and now they want to order the bacterial test. The order can be placed and the specimens are already in the laboratory. Not necessary, there is no need for additional collection. And the other significant one is there is no C. difficile target on the test. We know that C. difficile can be a difficult situation, especially for a admitted patient. And C. difficile have a specific double-step algorithm that also use the presence of the toxin, not only the PCR. So don't having this target on the test completely is a benefit, because even if the target is in the panel and the target is positive, we don't feel comfortable allowing our scientists working on the laboratory to ignore that positive test. So we need to make sure that the test is not present, and we avoid that issue with the regulations. So this is just starting to show the BDMAX, the bacteria, the viral panel. How was the cost-benefit analysis? So in 1,336 medical records that were reviewed from 16 hospitals, it was in Spain, there was a cost reduction of $27 per patient and $187 per children. The most significant factor influencing the cost was the reduction of hospital stay, fewer emergency room revisit, and a lower probability of hospitalization in the ER. So doing the whole evaluation, we were able to evaluate certain parameters. But it's obvious that having a rapid diagnostic, something that can be done in hours instead of days, can facilitate the management of those patients, can optimize treatment, and put actually patient in the right antimicrobial if it's required, or if not, completely stop or de-escalate antimicrobial use. We also know that some of, when we work GIs, when we work stool culture, some of these organisms are epidemiologically significant, and we need to work closely with the Department of Health. And this is something is critical. If testing is done in culture and transition is going to be done to PCR, to molecular diagnostic, to engage with the public health department in advance, to clarify the process, how some of these findings going to be addressed. When we have a positive for Salmonella, Shigella, Vibrio, or Yersinia enterocolitica, they internally order a stool culture for ID and AST. This is a customized 1 or 2 plate culture that is intended only to identify this organism that was found by PCR. This is intended for identification and susceptibility, specifically for Shigella, Salmonella, and Vibrio to be able to speciate, and the isolate is sent to the Department of Health. If it's positive for Shiga toxin, we also send we set up a GN broth directly for the sample, and or the specimen is also sent to the Department of Health. If it's negative, we don't do any additional reflex. So the intention of that is reflex only the positive if they are epidemiologically significant for working together with the Department of Health. One of the findings that we have is now we not only test for Shiga toxin, but enterotoxigenic E. coli. The enterotoxigenic E. coli is not required to be sent to the Department of Health. So when we have this finding, we don't need to do any additional isolation or submission. We only submit an electronic record that indicates that we found enterotoxigenic E. coli. So in this slide, we're trying to show the difference on the inpatient and outpatient, but also the prevalence and the volume that we've been actually testing for bacterial. And this is specific bacterial panel. So the total for inpatient outpatient around 9,500. You can see that is more prevalent for inpatients. Patient has been admitted around 7,600, 80% of all the volume for bacteria. And also you can see that the positive rate across inpatient and outpatient is almost the same, between 6 and 8%. Salmonella and Campylobacter is the most predominant. But the other interesting thing is, since we were not able to test for enterotoxigenic E. coli, for the 2 different locations, enterotoxigenic E. coli is actually significant, it's prevalent. For the outpatient is the second most common detection, and in the case of inpatient is the 4th after the Shigella. In the case of viral panel, we can see also a significant volume, especially for inpatient, and the positive rate is higher. We have a more prevalent GI infection by viruses than by bacteria, 15% in general, but in outpatient 11%, for outpatient 16%. The other significant finding is norovirus is the most predominant virus, rotavirus the second most common, but sapovirus is not really too far away. So it's interesting that sapovirus have almost the same prevalence as rotavirus. And there was a virus that we were not able to detect previously. We can also see astrovirus not too far away. So this could explain some cases when the patient is symptomatic, but the previous panel that we used in our facility was negative because lacked these 2 specific targets. In the case of parasite, is also surprising. The prevalence is less than 2%. It's between 1.2% and 2.4%. The volume is less. The parasites, the bacteria and viruses, with only 1,900, close to 2,000. Again, inpatient, highly prevalent. Specifically, the volume for inpatient is high. So this is something that we're trying to work to trying to coordinate better, because we know that this parasite infection, based on the prevalence, is very low. So there is probably an opportunity to improve the utilization of this target. Giardia lamblia is the most common parasite detected, and this is something that we used to see also with the antigen test before moving to PCR. So in conclusive, in the volume aspect, we can see that the viral is the most predominant and is the most prevalent infection between the 3 groups. where the parasite is the less prevalent. So if we have to create following a clinical presentation, but if we have to include the prevalence and epidemiology of this organism, we can see the viral PCR probably will be the best test to order initially, followed by bacterial and then by parasite. But it's always important to mention that the clinical presentation is the one that should guide what is the best panel to order at a specific time. So the improvement that we were able to evaluate was from the perspective of the laboratory, when the specimen was received to the result, not only receiving the specimen, processing the sample, and releasing the result was only 5.5 hours. Was a reduction in diagnostic time in less than 24 hours from the moment that the clinical suspicious was done and the result was released. And the time to appropriate management also improved, not only for therapeutic management, but even for infection prevention measure, to be able to be for sure that the patient is appropriately managed, not only for the antimicrobial utilization, if they have to be escalated or de-escalated, but if the patient was an appropriate infection prevention control measure in that moment. And as a summary, well, the BDMAX offer a flexible utilization for optimization of panel, is cost effective, and also laboratory stewardship or diagnostic stewardship. So from this perspective, we are able to offer a specific panel for a specific clinical condition, have a comprehensive list of target that is also in an important perspective, since we know that some of the prevalence can vary across the regions in the US, but it can also offer the opportunity to be able to explore and understand prevalence and epidemiology of other targets. There is no C. difficile target in this particular panel. There is another test that is for C. difficile that is available also in the BDMAX, and based on the perspective of diagnostic for C. difficile, the PCR should be used in a double-step algorithm. And this test is offered separate, but not in the GI panel. For us, it was interesting to better understand the prevalence of enterotoxigenic coli, sapovirus, and astrovirus, something that we could not before. So now we have a better perspective of these other three agents and be able to reduce the setup process and the rapid turnaround time. So offering a rapid turnaround time for detection of a significant pathogen, but also being able to report negative in just 5.5 hours versus 7 days is a significant improvement for utilization, for antimicrobial utilization, for patient management, but also in general for antimicrobial stewardship. So with this summary in my presentation, if you have any specific question, I will be happy to answer, or any comment. Thank you.
Thank you, Dr. Alexander and Murray, for your informative presentations. As we will now start the live Q&A portion of the webinar, I'd like to welcome Kayla to join us now. And to our audience, if you have any questions you would like to ask, please do so now. Just type them into the Ask a Question box located on the far left of your screen, and we will answer as many of your questions we have time for. So Kayla, I'm going to pass it over to you for the live Q&A.
Thanks, Christina. So let's get started. So our first question is going to be for Dr. Alexander. For a lab who is considering moving from a large panel type testing for viral, parasite, and bacterial GI pathogens all in one panel, when they're moving to targeted panels that are split up by pathogen type, what advice would you give to maybe help clinicians on ordering those targeted panels? So, maybe if general practice providers are seeing patients in like an outpatient setting, and they need help with knowing when they should order which panel, what advice would you give?
Yeah, well, thank you for the question. The point when moving from a large panel to a separate panel would be to also offer an education based on clinical presentation. I mean, clinicians are evaluating and using the clinical judgment to decide testing, and if they are used to just place one order, it's important to remind them and provide some clinical information about why we separated the target, the significance of that separation of target, and also the clinical presentation, the bacteria, viruses, and parasites can present, especially the epidemiological background for those three different group of infectious agents. At this point, the clinician, with this additional information, we should be able to provide back to them feedback, how the ordering pattern have changed, and any additional information, especially when epidemiological and prevalence data become available. So I say that in general would be education, not order for ordering, but why, based on the clinical presentation, the decision was made.
Yes, that's great insight. And could you maybe go into a little bit on how these tests might be reimbursed in the United States? This would be US specific information, but would that have any impact?
Yeah, one of the significant aspect right now is especially with multiplex PCR, especially with large panel, some of the third party payers insurance are being denying some of the reimbursement for some of these panel because they are actually requiring that this panel be used in more clinical context. So being able to have this panel separate and being able to submit those requests to payers having the panel separate can benefit this process, because we can now actually submit a request for reimbursement based on a panel that was ordered in consequence with a specific clinical diagnosis. So this can facilitate the regulation and laboratory reimbursement, having this panel just separate for this, specifically for all the administration process for requesting this reimbursement.
Thank you. That's a great answer. Murray, I'll turn it over to you. So you mentioned in your presentation about your enteric pathogen laboratory testing guide that is used. First of all, first part of the question would be, how important is that to your clinicians? And then two, how effective is that, do you think, as far as diagnostic stewardship efforts go?
Well, it's part of...
I'm sorry, this is for Murray.
Great question. And as far as looking at our testing guide, I think it's been very important to clinicians. We had a lot of inappropriate requesting, and to actually get them to look at what were the risk factors or what were the public health implications associated with the patient they're dealing with, as well as that whole clinical setting, as Dr. Alexandra has alluded to as well. Really important to guide them from that perspective. As far as effective diagnostic stewardship, definitely have seen it's helped in that respect. I mean, yes, we saw a drop-off in the number of samples we were getting, and that drop-off was the inappropriate requests. It really has helped the clinicians to target their requests to a more appropriate requesting pattern. So I think it's shown really good diagnostic stewardship.
Great, that's really great. And kind of going along with diagnostic stewardship, this could also be a question for Murray. Why do you think it's important not to include C. diff on a panel when testing patients with acute gastroenteritis symptoms?
You're looking at a very specific cohort of patients based on clinical presentation, based on their treatment history. Also, there are those who will have C. diff present, not necessarily acting as a pathogen as well. So you really want to be targeting your testing to those patients that are showing the history and the clinical signs and symptoms of C. diff, and being able to tie that result back in from that perspective. Just doing a carte blanche testing, you're going to pick up all of those people who may actually just be colonized with the organism, as opposed to it actually acting as a pathogen. I'm sure Dr. Alexander can probably add further to that.
Sure, thank you. I think just like Murray mentioned, I think it's important to understand the epidemiology and the clinical condition for CDI.
So as a diagnostic, we know that CDI, C. difficile, different than the other organism found in one of these panels, C. difficile can be a colonizing organism. So the presence of diarrhea or the presence of loose stool in a patient with colonized with Clostridioides difficile not necessarily means a Clostridium difficile infection. So the double sterile algorithm to improve the sensitivity, but also the specificity to be able to detect active infection is critical. So include a Clostridioides difficile in a multiplex PCR panel for bacteria by itself doesn't have the same diagnostic significance when the test is being done in an appropriate measure, patient considering the time of admission, use of antimicrobial, the number of a stool in 24 hours, and the double step algorithm that is recommended.
Yeah, yes. I'm a nurse, and we would have to make sure, that patient hadn't had laxative use in the last so many hours, or their diarrhea wasn't explained by some other method, like maybe they recently started tube feedings or something like that. So yes, it's very a select patient population that you should be testing for C. diff infection. Got another question for Dr. Alexander. So your positivity rate was highest, right, with your viral panels, or for viruses compared to, either the bacterial or parasite panels. Why do you think it's important to test patients for viral GI pathogens when there's really not much to be done as far as treatment for those infections?
Yeah, so the significance comes also from the perspective of the location. If you saw in the data that I show, 85% of the test was done in admitted patients. And those patients that are being admitted, multiple testing have been done in the moment. Having a diagnostic and knowing that the bacteria or the diarrhea is caused by the virus, instead to be a bacterial infection or a C. difficile, in the case the patient is being admitted for a little bit longer, I think it's critical to be able to narrow for the management. We know that this can look like, well, it's no bacteria, it's no C. difficile. We can assume that it's virus, but also the assumption, I don't think that at this point should be required. I think we should be able for certain to say that there is a viral infection, and that we'll be able to document evidence of a viral infection that can support the changement of treatment, management, and even we are now able to see that the prevalence of viruses is double of the bacteria. So with this information, we can go back and provide that feedback to clinician indicating, well, now 15 to 16% of the infection diarrhea that we have been seeing is actually caused by viruses versus 7% bacteria. So they can also use this information to change the way that the order is requested and how the test is done.
Right, that's great information as well. And this, I think we have time for one more question. This could be for either Murray or Dr. Alexander. For any of these tests, would they be used as tests of cure? Meaning to assess whether or not this infection is completed. It's this patient is no longer infected with a pathogen.
From our perspective, as a general rule, we don't encourage tests of cure. However, in certain public health settings, there are certain pathogens that they want to make sure the person has cleared before they are allowed to return to work or school or whatever. In which case, a test of cure is great. The thing with molecular testing is it is so sensitive. So for some pathogens, like for example, Salmonella, if they want a test of cure, we'll generally do a culture rather than a molecular test to see whether there's viable organism there, as opposed to picking up residual DNA from that particular organism. So depending on the pathogen and depending on the actual setting, will determine whether we do cultural molecular. In most cases, not appropriate to do either.
Yeah, just to I agree with Moray. Beside epidemiological purposes, the culture should be done. The PCR for as a test of cure, I don't think that is necessary. I think the clinical reevaluation and response should be the decision criteria for considering a patient to improvement or cure from that particular infection.
Agreed. Okay, well, thank you so much. This is going to conclude our session today. Dr. Alexander or Marie, do you have any final comments for our audience?
Just thank you very much for joining us and for the opportunity for us to share our experience.
Yes, thank you, everyone, and thank you to the team of BD for allowing us to present our finding, provide some more information about this particular topic.
Of course, thank you very much for participating. I will pass it back over to our moderator to conclude.
Thank you, Kayla. And thank you to Dr. Alexander and to Murray for their time today and their important research. We would also like to thank LabRoots and our sponsor, BD, for underwriting today's educational webcast. Now, before we go, I do want to thank our audience for joining us today and for their interesting questions. There were some questions we did not have time to answer today, and additionally, those that are submitted during the on-demand period, they will be addressed by our speakers via the contact information you provided at the time of registration. Today's webcast can be viewed on demand, and LabRoots will alert you via email when it is available for replay. And we encourage you to share that email with your colleagues and friends who may have missed today's live event. That's all for now. Until next time, everyone, thanks for joining us. Have a great day.